Good afternoon. We will continue with our ground round. I will introduce Dr. Rawan Shabib. Dr. Rawan Shabib, he finished the medicine studies in the King Saud University. Later on, he joined our hospital. He was a resident. Later on, he did a fellowship in corneal and anterior segment. And in the last 2 years, he joined us as a consultant. He's working in the corneal and anterior segment division. Today, the talk is about microbial culture of donor corneoscleral ring following keratoplasty. This was her fellowship thesis. He published her thesis recently in International Ophthalmology Journal. Welcome, Dr. Rawan Shabib. Please continue with your presentation.
Hello, assalamu alaikum, good afternoon. Thank you, Dr. Osorio, and it's my pleasure to present the grand round today, which is going to be about an uncommon but potential source of microbial infection following keratoplasty. So infectious keratitis and endophthalmitis is a major concern following keratoplasty, where in the United States, the incidence of infectious keratitis following corneal graft is between 4 to 4.9%, and the infectious and endophthalmitis following keratoplasty is between 0.1 to 0.77%. A report from Bank Association of America on the microbial infections following keratoplasty, they found increasing incidence of keratitis and endophthalmitis following keratoplasty, especially after endothelial keratoplasties. And the most commonly cultural organism was Candida infection in both endophthalmitis and keratitis cases. When it comes to local studies in KKISH, we have the incidence of infectious keratitis following keratoplasty is between 4.9 to 12%, and the infectious endophthalmitis following transplantation is between 0.2 to 0.68%, which these rates are consistent with the internationally reported rates. The risk factors of infections following keratoplasty includes epithelial defect, exposed sutures, contact lens wear after surgery, and ocular surface disorders such as trichitis. And one of the risk factors of infections following keratoplasty is contamination of the donor tissue. The contamination can be bacterial or fungal contamination, and it can occur at any time between the procurement of the tissue to placement. And in absence of infiltrate in the graft, there is no reliable signs of the time of the occurrence. And it's not clear whether it is a contamination or it's a part of the ocular flora, as one of the studies were able to culture Candida from the conjunctival sac and the eyelids of the normal eyes. One of the studies shows that a recent hospitalization prior to death can increase the risk of donor contamination and post-keratoplasty infection, which is related to the nosocomial infections. Bank Association of America had set out standards to reduce the cross-contamination between from donor to recipient. In a stage of donor selection, they are excluding all tissues from donors with active bacterial, viral, or fungal septicemia, or patients or donors who had infectious endocarditis or ocular inflammation before death. And in a stage of donor preparation, they used to lower the body temperature, and they place ice over the eyes to reduce the metabolic demand of the eye, which reduced the growth of the bacteria and fungi. And they have disinfection protocols with the washing or flushing the donor tissue with povidone and iodine. And when it comes to preservation techniques, Optizol media is a FDA approved and the most commonly used storage media in the United States to store the tissues. It is a hypothermic medium that contains a broad spectrum antibiotics but doesn't contain antifungals. And it has a color indicator which can detect some of the bacterial contamination, but it doesn't reliably detect the fungal contamination of the storage media. And since introduction of gentamicin and streptomycin in Optizol in the early 90s, several reports shows decreased incidence of bacterial keratitis and endophthalmitis after surgery. Another FDA-approved storage media is Life4 media, which is similar to Optizol media, but it is supplied with insulin and glutathione. Another storage media is an organ culture media, which is majority of eye banks in Europe are using it to store the corneas. And it has advantage that the cornea can be stored to up to 4 weeks, and it is supplied with amphotericin B as a fungicidal of choice of their storage solution. And the most commonly used initial concentrations of amphotericin is 0.25 micron. In one study, it was compared the frequency of positive rim culture after a hypothermic storage versus organ culture storage. And it was found that after hypothermic storage in Optizol, the rate was 9.8 compared to organ culture media, which was 1.3%. Another study found that almost 99% of the donor rims are sterile after the organ culture. Which may be related to the longer preservation time, which allow for microbiological testing and then excluding the tissue before surgery. Regarding the mean preservation time is one of the factors that could be related to the contamination of the donor tissue. One of the studies reported that a donor corneas that is stored for 4 days or more was associated with a threefold elevation in the risk of fungal endophthalmitis compared to bacterial endophthalmitis. However, in a large multi-center randomized control trial, which is a cornea preservation time study, they found that there were no association between a longer preservation time and incidence of positive donor rim or post-operative infections. Another factor is the death to preservation time. And there is a paucity in the literature regarding the relation between longer preservation time and development of the positive culture of the donor rim or the post-operative infections. This is two studies. The first one is from Denmark, of case series of 11 patients who had positive culture of the donor rim, which was both candida and bacterial cultures. The storage media was Optizol media, and all corneas were imported from a single eye bank in United States. The mean death to preservation time in this study was 18 hours, and the rate of infections post-operatively was 27%. Another study from Germany, they used the organ culture media, and they found that the longer death to preservation time significantly influenced the risk of contamination with a peak to 13 to 24 hours. So one study found that the death to preservation time of 6 hours or more is associated with a greater epithelial sloughing. So there is a positive correlation between increased post-operative epitheliopathy and increased death to preservation time. Regarding the culture of the donor rim, it was required by Eye Bank Association of America in the past, but it's not required nowadays. And they stopped being a requirement after 2 publications showed that there is a poor correlation between the results of the culture of the donor rim and endophthalmitis. So in the US, not all eye banks are doing, it's not mandatory to do the culture of the donor rim because of its also additional cost on the hospital and practices. However, in the Eye Bank Association of America Adverse Reaction Registry, they found that between 1991 to 2013, that the rate of 344 cases had endophthalmitis, and 42% of them had positive culture matching the recipient vitreous tab culture. The most common organism reported to the Adverse Reaction Registry was Streptococcus, followed by fungi, then Staphylococcus. This is a local study from KKish showing the endophthalmitis from contaminated donors following penetrating keratoplasty. They found that 6 patients had endophthalmitis and all of them had contaminated donor rims. And they found that the rate is higher in the corneas that was imported from Sri Lanka compared to the corneas from the United States. And their conclusion was to supporting the culturing of the donor rim and starting the prophylaxis in culture positive cases. Another case report from our hospital, it was a case report of fungal keratitis, 146 days following keratoplasty. And the culture of the donor rim was positive for Candida glabrata, and their conclusion also supporting the culturing of the donor rim and starting the prophylaxis in a positive donor rim case. So we conduct, there is a study, this is a meta-analysis on the prognostic role of donor rim culture in corneal transplantation, where the rate of endophthalmitis was 0.2%, and the culture positive donor cornea increased the risk of endophthalmitis to 1%. They found also that the fungal isolation from donor rim predict 3% probability of fungal endophthalmitis with high specificity and sensitivity. So we conducted a study in KKISH about the incidence and outcome of transplantation of fungal culture positive donor corneoscleral rim in optical keratoplasty. The purpose of this study was to determine the incidence of fungal culture positive donor rim after keratoplasty from 2006 to 2016 at King Khalid Eye Specialist Hospital, and to report the visual and clinical outcome of all culture positive cases. This study was a retrospective study. We included all patients who underwent keratoplasty and had positive culture of the donor rim from 2006 till 2016. And we excluded the patients who had a tectonic therapeutic keratoplasty or had follow-up of less than 6 months or had mixed bacterial or mixed bacterial and fungal cultures from donor corneoscleral rim. A data collection sheet were including data about the recipient and the donor tissue. From the recipient, we collected the data about the primary diagnosis, the use of medical prophylaxis, the method of prophylaxis, and the duration of the prophylaxis. And from donor tissue, death to preservation time, death to surgery time, and fungal culture species was recorded. So the primary outcome measure was the development of fungal keratitis or endophthalmitis after keratoplasty using the contaminated tissue. And the secondary outcome measure was the impact of post-operative prophylaxis on the final outcome and long-term clinical outcome and any associated complications. So out of total 9,620 grafts that was done in 10 years, 145 cases, which represent 1.5%, had fungal culture positive donor rim. Unfortunately, there were no cases of post-keratoplasty fungal endophthalmitis or keratitis. Regarding the patient's demographics, the median age of recipient was 32 years, and the median median duration of follow-up was 4.8 years. Regarding the donor tissue demographics, the mean age was 54.4 years. The median death to preservation time was 8 hours, and the median mean preservation time was 10 days. The cause of donor death, the commonest cause was coronary artery disease in 33.1% of the donors, followed by cancer in 15.9%. Regarding the isolates, 87.6% had candida cultured from the donor rim, while 12.4% had non-candida cultures. And this table represents the fungal species from the donor rims. Regarding the indication of keratoplasty, 62.1% had keratoplasty for keratoconus, and 13.1% for a corneal scar, and 3.1% for corneal dystrophies. Regarding the type of procedure, 66.9% had the PKP, and DALC was done in 26.9%. 4.8% had DASIK, and 1.4% had Boston keratoprosthesis. Regarding the use of antifungal prophylaxis, it was used empirically in only 8 patients with positive culture. And out of those 8 patients, 6 patients had clear graft at the final follow-up. Regarding the post-operative complications, 22.7% of the patients had an episode of graft rejection. 8.7% had glaucoma, which developed after surgery, and 4.7% had suture-related keratitis. With subgroup analysis of the graft rejection in this study, we found that the median age was 44.5 years in the patients who had graft rejection, 85.3% had PKP and 3 patients had DASIC. The primary indication in this group was keratoconus. And the other risk factors of rejections, it was found in 4 patients. 2 had a significant corneal vascularization, which involved 2 or more quadrants, and 2 had pre-existing glaucoma. And at the final follow-up, 47% had a clear graft and 44 had failed graft. Regarding the visual acuity at the final follow-up, 64.1% had good vision, 20/60 or better at the final follow-up, and 17.2 had poor vision less than 2400 at the final follow-up. Regarding the graft status at the final follow-up, 79.3% had clear graft, 6.9% had opacified graft, and 13.8 end up with the failed graft. So this study was a 10-year incidence of fungal culture positive donor rim following keratoplasty in our hospital. The incidence was extremely low. It was 1.5%. And there were no cases of keratitis and endophthalmitis post-keratoplasty, which could be related to that the median age of our recipients was young, 32 years, when compared to the published study who had positive culture of the donor rim and developed infections, which is 77 or 76 years. And another thing is the indication of keratoplasty. In our series, it was keratoconus in 62%, while in the other studies who developed infection was pseudophakic bullous keratopathy or failed graft. Another factor that the younger patients with the healthier ocular surface may be a protective factor from developing infection when receiving the positive culture of the donor rim. Another factor could be that the culture of the fungal isolates in this study, it was rare to few in all colonies, in all cases. And the fungal load in the contaminated rim was extremely low. So maybe a larger dose of fungus are needed to develop infection following keratoplasty. There's a lot of papers in the literature regarding the addition of the antifungal to the culture media. However, there's no large randomized control trial to evaluate the efficacy of routine antifungal supplementation to the corneal storage media. Some study reported that adding voriconazole with a concentration 100 microgram to the corneal storage media can reduce the fungal growth. However, some of the studies were able to culture Candida albicans or glabrata from the media supplemented with a lower dose of voriconazole of 50 microgram per ml. Another study shows that the addition of the amphotericin B to optizol media is effective in suppressing the growth of the Candida with the minimal effect on the graft quality. However, with increasing resistance to Candida species to antimycotic agents due to genetic alterations, which could reduce the efficacy of amphotericin in the culture medium. Regarding the antifungal prophylaxis, we don't have a specific guideline for prophylaxis using antifungal in the culture positive cases, either in KICKISH or even in the literature. And we had only 8 patients who received the prophylaxis based on the surgeon preference, whether it's systemic or topical. Some authors have suggested that prophylaxis in all cases of the culture positive donor rim, and they reported good efficacy in reducing the risk of infection post-operatively. One of the studies was published recently by Price. He found that routine implementation of antifungal in a patient who is receiving the fungal culture positive is a problematic because of lack of definitive data regarding the optimal route of administration, the duration of the prophylaxis, and the relative efficacy of different antifungal agents. And he reported that the use of prophylaxis alone is have not been proven to be effective, and the systemic medications carries risks of liver toxicity and potential interaction with the other drugs. And from his point of view, that the treatment of post-keratoplasty fungal infection typically involves the removal of the lenticule or the graft in endothelial keratoplasty. In this study, the rejection rate was considered high. It was 22.7%. And only 4 patients had pre-existing risk factors. 2 had a corneal vascularization and 2 had a glaucoma. Where the median age was young, 44.5%, and the primary diagnosis was keratoconus. When we compare this rate with the previously published rate in KKISH, in 2009, Wagner reported that the rate of rejection in KKISH after optical keratoplasty was 17.3%. However, in this study or in our series, it was high. It was 22.7%. So we just proposed that the positive fungal culture of the donor rim might be an independent risk factor for graft rejection in absence of other risk factors, which could be related to that the fungal antigen stimulate the immunity directly or indirectly lead to activation of the immune system. However, this hypothesis needs further investigation and studies. So this picture summarizes what's in the literature regarding the general consideration if you have a culture positive case without clinical evidence of the recipient infection. It was published recently that you need to inform the eye bank of origin and check the mate cornea if he developed any adverse reaction. And plan for close monitoring of the patient. Consider initiation of prophylaxis in the cases it depends on the sensitivity of the cultures. And a combination between the systemic and topical is advised in the cases of monocular patients or infection in the mate cornea recipient, and to consider change in the topical steroid regime. So in conclusion, the rate of positive culture of the donor rim following keratoplasty is extremely low. Post-keratoplasty fungal keratitis and endophthalmitis is rare, but when it occurs, it can lead to devastating complications. So we recommend prophylaxis and close monitoring of all culture-positive cases, and we need further studies to measure the efficacy and the outcome using a prophylaxis and to establish guidelines that could be implemented in the culture-positive cases. And thank you.
Thank you, Dr. Rawan. We don't have questions in the chat, but I want to ask you a question regarding the rejection in these patients.
Mm-hmm.
Recently, we had, we had recently 3 cases in the last 2 years after you finished the review of your 10-year period. We found 3 cases, and unfortunately, we have a positive ring, culture positive ring to Candida, and after that, the patient, any of them develop infection, but the patient unfortunately develops severe inflammation and later on rejection. My question is regarding this rejection. The last study that you showed, Dr. Price, and your study, also the study showed that this patient are prone to develop inflammation and rejection. Do you think that this rejection is related because we are tapering the corticosteroids, or maybe the rejection is related with the inflammation is related with the maybe low degree inflammation related with the candida? What is your opinion regarding this rejection?
We thought that because what's in the literature, it's not clear whether there is a rejection relationship between having a rejection and the positive culture of the donor rim, but it was like an observation in our study that it is high. So we think, or hypothesis, it's a hypothesis that maybe having a positive culture of the donor rim like stimulate the immunity to cause more inflammation and can trigger rejection. So it's not clear actually in the literature whether there is a relationship between the rejection and having positive culture of the donor rim, which need maybe a prospective studies or close observation of patients who has positive culture to see whether if there is an effect or not, or the rejection is one of the side effects of having a positive culture or of donor rim or not.
Yes, I agree with you. I saw the 3 patients that recently have this severe inflammation after Candida positive ring culture. And this patient, they have really severe inflammation. Even the consultant continue with the corticosteroids. And also they started prophylactic systemic and topical amphotericin. But the patient developed severe inflammation and finally rejection. I don't know what happened finally. I don't know if they photographed the patient or not. But I am sure that this patient that they have positive ring culture, fungal positive ring culture, this patient in the more or less around 30% of them will develop rejection and severe inflammation, and maybe it's a low degree infection. It's so difficult to treat this patient when you really have endophthalmitis of keratitis. It's so difficult. This is one is well known the epidemic of the fungal infection after DSIC. This is the main concern, and this is the reason that we start this study. But in our hospital, it was the positive ring was more related with keratoconus and penetrating keratoplasty. Unfortunately, it was not a disc patient, only 2 patients that you show.
Yeah.
But worldwide, the concern is related with the disc patient.
Yeah.
The
And
last
actually,
week, let's continue, please.
yeah, I think the challenge with the DASIC patients, because the infection will be in the interface, deep in the interface, so it will be difficult to culture and to know or to relate to see whether it is related to the fungal, the culture of the donor rim or not. So I think this is why it's like internationally they are concerned about the fungal infection post DASIC. And they recommend, even if they are not doing the fungal culture, the culture of the donor rim, they do it at least for the patient's post-endothelial keratoplasty, because this maybe guide the physician to the treatment in case of positive culture.
Yes, in this is very difficult the treatment.
Mm-hmm.
The different article they have been published about it. Most of the patients, 95% of them, finally they remove the disc
The
lenticle,
lenticle.
and most of the patients finish in penetrating keratoplasty with AC washout. It's
Mm-hmm.
so difficult to treat this patient with disc and positive fungal ring culture. The
Mm-hmm.
last week, finally, the Lions Eye Bank of Florida, they received the approval of FDA for one, they developed one component with amphotericin. I don't remember what is nanoparticles or what is this, but they received the approval, and
Mm-hmm.
they will start to use this, they will start to add this amphotericin for the normal culture media. I don't know if maybe if it will be used only for this patient with this ecodemic. I don't know. Maybe they will start to do it. But recently they have the approval finally coming from FDA.
Mm-hmm.
There is one question here for Dr. Rafal Iraq. Is a okay? Did you come across any study talking about the rate of graft failure requiring repeating graft in patients having donor positive cultures?
There's a study about the rate of the failure, of the graft failure, but it's not related to the positive culture of the donor rim. I didn't see any study related to that.
Yes, me neither. Me neither. We know that the DSEC, after DSEC, yeah, they have to do PKP. The patient
Mm-hmm.
finishes finally in PKP. They have to remove everything. It's not enough to remove the lenticle and wash the anterior chamber and inject the voriconazole and amphotericin in the AC. The other question, is there any specific recommendation or superiority to the antibiotic prophylaxis recommended for the monocular patient?
Um, you mean that specificity regarding the type of the antifungal? Is this the question?
Yes,
Yeah, so
exactly.
it depends on the sensitivity of the fungal. So now in our lab, they are doing the sensitivity for Candida. So they usually start with amphotericin, and then we check the sensitivity of the Candida. Regarding the systemic, usually they are using azoles, voriconazole or azoles. Yeah, so it's amphotericin. We usually start with amphotericin. We change it based on the sensitivity of the organism.
Yes, following the study that they did in India, that it was published in the last 6 years, the amphotericin is still the gold standard for the treatment of the Candida. Most of the patients have Candida infection.
Mm-hmm.
Even we are using the amphotericin for more than 40 years, the resistance rate is so low, it's lower than 2%.
Mm-hmm.
This is still a good medication for Candida. The azoles, mainly the voriconazole, the India group report right now a resistance rate around 15%, and
Mm-hmm.
this increase of the resistance was
Yes.
only, they compare only a 2 years period. We have to take care in consideration that maybe we have to do the recommendation will be with amphotericin,
Mm-hmm.
topical and intracameral, maybe is necessary,
Mm-hmm.
and systemic depend of the physician decision.
Yeah.
Okay. I don't know if any anterior segment consultant have any question, or fellows or residents.
If any of the anterior segment wants to share his experience with having a positive culture post keratoplasty.
Yes, I am checking right now who are connecting. I don't know if Dr. Sadar Harvey to have one patient with this severe inflammation, or Dr. Kirado, Dr. Ahad. I don't know if they are connecting right now.
I think Dr. Qirat is around.
I don't know. I am checking right now. In my experience, I always wash the cornea, the donor cornea with BSS. I always use one bottle of BSS, and I always wash. I know that Dr. Ahad also is washing the donor's cornea. And
Before
almost
PKP or
in
before?
more than 5 years that I am working in the hospital, I only have one positive ring culture. It was Klebsiella, but all of them was negative. I don't know how many PKP or LKP or this I did in the last 5 years in the hospital. But only one was positive and was Klebsiella. But always my reports are negative. And I was talking with Dr. Ahad and he had the same experience. This is the reason why I recommend my fellows that always they have to wash the donor cornea.
Yeah.
Gentle washing in the epithelial side. I am washing more rough, but in the epithelial side I put in the drops only. But this is my experience. Only one positive culture, bacterial Klebsiella, in more than 5 years. I know that Dr. Ahad have the same experience.
For me, I had a case of a positive culture, fungal culture of the donor rim following a DASEC case. And I was notified like 3 or 4 days post-operatively, and I closely monitored the patient. I started him on topical amphotericin because he was old patient. So I started him only on topical amphotericin. And I didn't find any inflammation post-operatively. Nothing was significant actually. And I'm following him now for 1.5 years. He's doing great. There's no inflammation, no complications. But what was weird that he presented to my clinic 2 weeks post-operatively, and he had like central like pocket of fluids in the interface, like 2 millimeter, or I would say detachment in the interface, which was not there when I discharged the patient. So I did I rebubbled him, and he ended up with good vision, and I didn't see any inflammation post-operatively. I kept him on amphotericin for 3 months, and the steroid course was usual. It was QID, and then I taper it.
This is so important, the steroid use. Maybe if you are not tapering the steroid, you are reducing the rate of rejection in this kind of patient.
Yeah.
Dr. Kirat is around and he is connected, but I don't know if he wants to share his experience. Also, Dr. Mulak is connected. I don't know if Dr. Mulak will explain us what is the protocol in our hospital when we have one positive culture. We have enough time. We have at least 10 more minutes. Dr. Mulak, Dr. Kirat. Okay. Dr. Alfred is also connected. He is around. Don't know Dr. Alfred. He has a large experience. He was the chief of the bank for 20 years.
There's, I think,
okay.
There's one question from Yasser.
Okay.
Dr. Yasser.
Okay, go ahead, please. Around the micro, please talk.
Yes, doctor.
Dr. Mugler replied, we don't have a specific protocol. It all depends on the surgeon for the choice of antifungal, but we must inform the surgeon ASAP when we get the result of positive ring. Yeah, there is a protocol in the hospital. There is a policy, and the policy is clear that the technician of the laboratory have to inform the surgeon and the IBAN at the same time. They have to inform by telephone, phone call, and also by email. But it's true, we don't have a protocol, a specific protocol.
Yeah, even in the literature, there is no specific protocol. It usually depends on the surgeon's preference. So actually, maybe we need a prospective study to see the effect of starting the antifungal and topical or systemic, and its effect on the graft and the infections post-operatively.
Yes, also the concern is the DSEC patient. You have a DSEC patient and the culture is becoming positive. You have to be aware about maybe the patient will finish in PKP and maybe the patient need admission and systemic treatment. It's so difficult in DSEC.
Yeah,
Keep
exactly.
maybe the reaction, don't taper the corticosteroids and start the prophylactic amphotericin. Okay, Doctora Rawan, congratulations. You published your thesis, is what your fellowship teaches.
Yeah,
Excellent work,
thank you so much.
and see you around. Hopefully,
Thank
I
you.
will come back. I will come back soon. I am still stuck in Spain,
Okay.
but
So
I
have a
am.
good day.
Thank you. Have
Thank you. Thank you
I
very much.
enjoyed this session and have a good day for everyone.
Thank
Okay,
you. Thank you.
goodbye.
Bye.